if I gave the child water, he loved me. So I've been giving my child water, and I feel guilty about it. And I hear this story all the time. So to talk about Fanconi's and cystinosis, we have to do some physiology. So this is the overview of the body, and the kidneys are the most important organs in the body, and they're tucked back way in the back, so they're protected by everything else, and muscles and bone and stuff like that. And then if you go closer to the kidneys, you look at one kidney, and the kidneys are born with about 1 million filters, and each filter is similar. There's a little part where the blood goes through called the glomerulus, and there's tubules that run deep in the meat of the kidney and back out, and then they're what make the urine. And so the glomerulus filters a ton of fluid. So for a typical adult, 150 liters, 150 quarts of fluid is filtered through the glomerulus into the tubules. And almost all of it gets reabsorbed. So the proximal tubule and the distal tubule are just reabsorbing to try to get all that fluid back and only leave the waste products behind. And they work very hard 24/7. And what comes out is just the waste products and what you don't need. Well, with Fanconi syndrome, that early part of the kidney, that proximal tubule, doesn't work well. And because of that, a lot more fluid passes through. And so the body loses water, amino acids, sugar, phosphate, and other electrolytes like sodium and potassium and bicarbonate. And that's all called the Fanconi syndrome, and it's just, that's the name of it. But I got this picture from Paul Goodyear, and these are human nephrons that have been painstakingly microdissected from various people who had passed away. And normal glomerulus, and then that's the proximal tubule, and then this is a 5-month-old and a 6-month-old who passed away. And this is a 14-month-old with Fanconi's, probably cystinosis, because this was in the 50s. There's a glomerulus, and there's the distal tubule, but here, there's almost no cells. They've just died. Compare that to here. So the proximal tubule, which should be absorbing like 90% of the bicarbonate and the phosphate and stuff like that, it just doesn't work. And so the biologists at the time said, you know, this is so delicate and it just doesn't have the support and structure, so let's call it a swan neck. So if ever you've read about cystinosis, we talk about the swan neck deformity, which is in those nephrons. Anyway, the kidneys spill too much electrolytes. So your baby or you, if you have Fanconi syndrome, the blood is tested and your bicarbonate level is low. Bicarbonate in the blood being low equals acidosis. So there's a bunch of different names for the same thing. So we measure bicarbonate. So in your lab or your doctor might call it the bicarb, or you might see in the results in your parent portal this, or total CO2 or total CO2. It's all the same, just different words for the same thing, bicarbonate. Now bicarb is just baking soda, and bicarbonate neutralizes acid. The normal bicarbonate for a human being is around 22. And if the bicarbonate is low, there's too much acid in the system. So basically acid and baking soda, that's all we're talking about with acidosis. Now, normal situation, and this is a nice little visual. The body keeps the bicarbonate level at 22. So just imagine this bathtub and you've got the tap running. 22 is the top of the tap of the tub. So if the level in the body goes above 22, it spills over in the urine. So the kidney controls how much bicarbonate is in the blood, and if there's more than 22 or 23, it just dumps in the urine, and that's a normal person. But someone with cystinosis, they've got a hole in their bathtub. And so as the blood level gets up to 15 or 16, it starts leaking. And the more bicarb you give to raise the blood level to normal, the leak gets faster and faster and faster till you've got like Niagara Falls. And so this is why the kids need a huge amount of bicarbonate. Phosphate is the same thing. Basically, phosphate is leaked just like bicarbonate. Now, phosphate's really important for energy metabolism. If your phosphate level is really low, you can actually become weak and even paralyzed. But the body takes phosphate, mixes bicarbonate and calcium, and makes bone. So when you have cystinosis and your kidney is leaking too much phosphate, what happens is the bone is melted to release phosphate and bicarbonate and calcium to maintain your physiology. So when your child has a low bicarbonate or a low phosphate, the bones are actually being melted to provide an adequate amount to keep you alive in your bloodstream. And when this happens too much, it leads to rickets. And rickets, this is an x-ray of someone who should have straight lower legs and they're curved, and someone who has these big swollen knees because that's the joint not formed properly. And many children with rickets or cystinosis, especially if it's not well managed or late diagnosed, they tend to be short, and this is a big part of it, and they tend to have bowing of the knees and require surgery. This is all connected to the Fanconis. So you as a parent, you're told to do all sorts of things, and sometimes it's hard to fit everything into your day. So how important is all these drug doses? And that's what we're going to be talking about next. So this is a diagram that I'm going to use for the next bunch of slides. So this is time, and this is a blood level of something, and let's just say it's a blood level of bicarbonate. This red line here, 22, that's normal. Now your child who has cystinosis leaks too much bicarbonate, so the bicarb level is like 16 or something like that, and that's acid. When you give a dose of bicarbonate, the blood level quickly goes up past normal, but then the kidney leaks it, so it goes down, 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 and it gets back to 16 relatively quickly. So you can't just give one dose. You have to give multiple doses throughout the day because it's low, you raise it, but then the kidney pees it out, it drops down, you raise it, drops down, you raise it. So you have to give the phosphate and the bicarbonate multiple times a day. What happens if you only give it 2 or 3 times a day? Well, during the time you don't give it, there's going to be a period of time when the bicarbonate level is low, and for every minute or hour the bicarbonate level is low, the bones are being melted. So you're losing the benefit that you had from the earlier time of day when your bicarbonate level was good. So if you only give the bicarbonate a few times a day, you have periods of time when the bicarb is low. Why can't we just increase the dose? Give massive doses of bicarbonate and phosphate so that it goes way high, but it doesn't go too low, and you can only give the dose 2 or 3 times a day. Why not that? Well, big or bolus doses of bicarbonate and phosphate cause gastric distress. It's irritating, and they can cause vomiting and diarrhea. But if you give a sudden load of bicarbonate and phosphate, what happens is those chemicals grab the calcium in the blood and lower the calcium. And that causes jitteriness, muscle spasms, and tetany. And many cystinosis children will have episodes where their hands clench, or here this child's had their face just tapped and they have go into spasm, and people talk about tetany. So if you've gotten these abnormalities corrected too quickly in the hospital, especially by overenthusiastic doctors, many of the families have experienced tetany. So you can't give a big dose at any one time without that risk. Well, since the kidney works 24/7, is there any possibility of giving all these electrolytes all the time? And so some patients who are on overnight tube feeds, that works really good. You throw the bicarbonate, the citrate, the phosphate in the overnight tube feeds, and you at least get part of the day where everything's perfect. And then you might give an occasional dose during the day. So some families that do really well like that. Bicarbonate and phosphate are supplements. And in many parts of the world, and in the US Medicare, for example, supplements aren't covered by insurance. So we have a lot of families where they have difficulty paying for the bicarbonate supplements. and vitamins and things which are so important in cystinosis patients. And we're seeing this more and more. Like recently in California, they changed some laws, and patients who were able to get phosphate covered, the K-phos and sodium bicarbonate, all of a sudden are paying out of pocket for that. So we've started having to become a little more creative. And one of the things which is interesting is lemon juice. It turns out that lemon juice can be an alternative to potassium citrate for the treatment of cystinosis. And see, with potassium citrate and sodium citrate or bicarbonate, it makes your urine pH alkaline. When your urine pH is very alkaline, the phosphate, which your body leaks, can make stones. And so we've started noticing that there are some patients, when you switch some of their base supplements to lemon juice, which is an acid, it actually reduces their stone rates. So I've had at least 2 patients with cystinosis who were getting recurrent kidney stones, and when we switched their base supplement from bicarbonate and citrate to lemon juice, their stone production stopped. So that's really interesting. The other thing is, for some people, they're paying hundreds of dollars a month for citrate supplements. And it turns out you can get the very same thing on Amazon. If you go to the molecular gastronomy section, you can get kilograms of sodium citrate that's used in certain recipes and stuff like that for very cheap. And so you can work with your doctor or your nurse practitioner or coordinator and save a lot of money from copays, which unfortunately is a big deal. There are some people who have difficulty with sodium bicarbonate because it's irritating to their stomach. Babies aren't so bad, but the older people get, the more they get irritated by sodium bicarbonate. If you have insurance, you can get something called Bicarb. Now, Bicarb is enteric-coated bicarbonate pills. So just like Procysbi, where Procysbi is basically a cystagon with an enteric coating, Bicarb are pills of sodium bicarbonate with enteric coating, and if your insurance covers it, people find a lot less stomach irritation from Bicarb. One of the more complex issues, which is medicines can be taken at the same time, and some should not be taken together. And I often give this cartoon out that shows families what different supplements can be given together and what can't be. And I'm just pointing out here, like Procysbi can be given with sodium citrate. Yes, it can be given with potassium and phosphate, but it should never be given with carbonate, calcium, or bicarbonate. So it gets complicated. And why is that? Procysbi needs stomach acid to work properly. If you or if your child or you are on Procysbi, but you take strong antacids, which neutralize stomach acid, or you have chronic kidney disease, which reduces stomach acid, or you have delayed gastric emptying, which some patients have, where you might take a medicine and 4 hours later, if you vomit, you still see some of that medicine in the stomach, so it takes a long time to move through. All those things prevent the acid from developing in the stomach. And Procysbi is basically just plain old cystagon, plain old cysteamine, but it's in an enteric coating, and that enteric coating is pH sensitive. So in the acid stomach, it's intact. And then as your intestines open up and then the little beads move into your small bowel, and then the acid is neutralized, then the beads can release. Well, if your stomach doesn't have stomach acid, and Dr. Jenkins was talking earlier on about the different acid pH in water and milk and Coke. So if you don't have enough stomach acid, or if you take the Procysbi with water and where you live it's quite alkaline, you're actually taking Procysbi, which is $100 a pill, and converting it into a really expensive cystagon, because it's going to be released in your stomach and the whole beneficial effect of the Procysbi is wasted. So that's why acid is important. So it's important if you're on bicarbonate or calcium supplements, they should be taken more than an hour or 2 before or after the Procysbi. Try taking Procysbi with a source of acid like lemon juice, mixed either straight up or with a bit of water, or fruit juice other than grapefruit juice. And things like that can help the Procysbi work properly, and you get your best benefit from it. Sometimes we'll have patients who have stomach irritation or complications, or their Procysbi dose is really high, but they don't have a good 12-hour level. And you go through their 24-hour food diary and you find, okay, here's the Procysbi. It's given at 7:30, and they're giving sodium bicarbonate half an hour later. And so you just simply move the sodium bicarbonate away from being close to the Procysbi, and sometimes that can make a huge difference. All of a sudden, the delayed release capsules work, and you get a level, and you're having less stomach irritation. So it takes trial and error and understanding the disease. Sodium citrate. Sodium citrate gets converted by the liver to bicarbonate. So basically, sodium citrate and bicarbonate are both trying to correct the acidosis. But the nice thing about sodium citrate is it's a little bit acid to start with, so it gets along very nicely with Procysbi. The only thing you shouldn't give sodium citrate with is sodium bicarbonate, because the acid from sodium citrate and the bicarbonate will make burping, and people hate to burp. Potassium. Potassium gets along with just about everything. So you can mix potassium with your Procysbi, you can mix it with calcium, with sodium citrate, but you don't want to give calcium and phosphate at the same time, because they bind together and they form chalk, and you just poop it out. Some families find that their child drinks lots and lots of water, but they can start putting in some of the electrolytes in the water. And if you start at a very low level and slowly build it up, you can give the electrolytes consistently throughout the day whenever the child is chugging their water. So we can mix the potassium, the phosphate, and the citrate and the bicarbonate in their water. And when you start it very slow and slowly work it up, they don't notice it, they don't mind, and then you get this continuous level, and you're giving less big bolus doses throughout the day. And sometimes when you give a big squirt of bicarb or a big squirt of phosphate, it can cause the child to vomit or have diarrhea. But if you give it gradually, mixed in with the water, it works very well. Some families add all the day's electrolytes to the full day formula. So they mix up 24 hours worth of formula, and they just throw in the sodium, the potassium, the citrate, even the phosphate. And then it's just being given continuously throughout the day. But it's important, if you're doing that, if you're giving phosphate spread throughout the day, to remember calcium, because calcium and phosphate will bind, and whether the calcium comes from a supplement or from the formula, and it'll just go out in the poop. So if you have a child where you have to spread out their phosphate, you want to remember that the calcium and phosphate together are not going to be absorbed and to go in the bones. So you want to give them separately. So you need a dietary calcium supplement far away from a phosphate dose. Or give at least some of the formula without any phosphate in it. There are some people that say, oh yeah, my child gets calcitriol, I got that covered. Calcitriol is not calcium. Very commonly people think it's the same thing, and it's very different. Calcium is a mineral that goes into making bone. Calcitriol is a processed form of vitamin D, and that's a vitamin D that does not need your kidneys to function. And we use calcitriol in cystinosis patients to make the intestine absorb the phosphate better, so that you don't have to give your child so much. But if you're on calcitriol, you still need a calcium supplement at some other time point. They're not the same. Another thing you need to think about is, when is the blood tested? You see, going back to that graphic, if the level of bicarb is low and you give a medication dose, and then you go to the lab 1 or 2 hours later, you're going to see the blood test at the highest it's going to be for that entire day. And so it's great if you want to have a good result and to be told, good job. But what's going on the rest of the day? Especially if the bicarb level here is just barely normal, it's likely to be low for a good chunk of the rest of the day. So maybe you take your child sometimes to get their blood drawn halfway between one dose and the next dose to see where it is more on an average. Or even what I like to do is I like to see the worst. So I'll ask families to get their blood drawn right before the dose of bicarbonate or phosphate is needed. And then we see what is the worst. And if it's not too bad and the child's growing well, great. But if the child's not growing well and the bicarb is significantly below the normal, maybe they're spending a big part of their day acidotic, and that could be why the child isn't growing or why the child isn't feeling well, and you might need to give the doses of the bicarbonate and the phosphate a bit more frequently. So you have to play with this and play with your team to figure out what works best for you and your child. One thing that's important for sure, on the day you have your blood test, please, please, please don't do anything different than you normally do. Take all the meds at the normal time, take the same normal foods, same normal timing. So often what happens is people will do something differently right before the blood test because they want to look good. But that isn't helping your doctor or your nurse care for your child. What we want to know is what's happening most of the time. So don't change your process on the days that you're having blood drawn. Okay. Next, polyuria. Sorry? We're 5 minutes. Okay. So polyuria, which in the cystinosis world is known as serious urination. It's so true. One of the things that we have started to recognize is the quality of life is really affected by the amount of urine the child makes. And there's actually some things that you can do about it. So when the kidneys are unable to concentrate the urine, the more electrolytes that you are making the kidney pee out, the more water is being dragged with it. And this is just an instructional graphic. Your average adult excretes around 500 or 600 milliosmoles of solute a day. And so if your average adult can concentrate the urine really nicely, then they pee out a small amount of fluid. But if they can't concentrate, they have an obligatory urine output of 10, 15 liters. The more electrolytes we give the patient, remember, they're all going to go through the system, the more they're going to pee out. And so what that means is oftentimes when your doctor increases the dose of bicarbonate or increases the dose of phosphate, you notice your child's urine output gets worse. And that's because they have to pee out those electrolytes, and that drags water with it. Well, it turns out that there's a drug called indomethacin, which actually reduces the urine output in cystinosis patients, and it's been very controversial for a long time. Kidney specialists are always told in their training, tell people with kidney disease to never take nonsteroidals, Motrin, Advil, naproxen, indomethacin, because we know in big doses it can damage your kidneys. And so that's one of the things that we sort of learn in kidney school to never give your patients. But it turned out that in America, we follow that rule, and it's very rare for a kidney specialist to ever tell a patient to take indomethacin. But in Europe, in many parts of Europe, it's practically standard of care for cystinosis patients. So there was this tremendous controversy. French cystinosis patients are all on indomethacin, and very few Americans were. But there's a 40-year history of indomethacin in cystinosis. And goes back to this paper from Cyril Chandler at Guy's Hospital 40 years ago, where they gave indomethacin to patients with cystinosis, and their sodium levels got better, their potassium levels got better, their bicarbonate levels got better. So what indomethacin does is it's a non-steroidal anti-inflammatory, and it works by adjusting prostaglandins in the circulation of the capillaries around the tubules, and also the function of the tubules. Recently, just a few months ago, a paper was published which really made me comfortable to recommend indomethacin. This is an international cohort study that spanned 50 years, assessing the outcomes of children with nephropathic cystinosis in Europe. So there were 453 cystinosis patients from the UK, France, Germany, Italy, Netherlands, and Turkey. Of those patients, 43%, so 186 patients, were on indomethacin. And to be ID'd as being an indomethacin patient, you have had to be on it for a minimum of 5 years, or more than half of your life if you were less than age 10. So these were people who had long indomethacin exposures. And what they showed very clearly was there was no signal of any increase in kidney failure. Oops. If I can just show you, where is it here? The hazard ratio for indomethacin treatment was 0.95. So absolutely not even a hint of a signal that indomethacin actually hurt people's kidneys. But there's no doubt by giving indomethacin, it reduces the polyuria, it reduces the electrolyte requirements, and it improves people's quality of life. In early studies, especially from certain countries, there was evidence that people who were on indomethacin were taller as their final height than people who were not on indomethacin. Now, indomethacin isn't totally easy. In the liquid form, it irritates the stomach, so add that up to the cystagon and the other things that irritate the stomach, so it can cause ulcers and bleeding. Some people will say, why don't you just use Motrin? But there is some evidence that Motrin doesn't work as well. So what I do with my patients is once they're a little bit older, there are enteric-coated capsules which contain 75 milligram beads, and you can open the capsules and say if the child needs like about 30 milligrams, I tell the family, okay, open the capsule and just break it up into about 2 equal portions and give the beads today for half and then half the capsule tomorrow. And that reduces any gastric irritation and risk of stomach ulcers. Now in Europe, they have 25 milligram capsules that are enteric-coated, but they're not available in North America. I don't know if they're available in Canada. They might be available in Canada, but they're not available in the USA. And that would make life a whole lot easier. But clearly, with the patients that are on indomethacin, their quality of life is better. And so I'm starting to advocate for that. For the last couple of minutes, there's other things which we are using when some doctors in cystinosis clinics are using more than others, and one of them is diuretics. And you would think, why would a diuretic be used in someone who pees too much? But there's good data in patients with diabetes insipidus that you can reduce the urine output with a drug called chlorothiazide and with hydrochlorothiazide in patients who have diabetes insipidus. And there is some papers, this is from 1970, on using hydrochlorothiazide in cystinosis patients, and it reduced the excretion of bicarbonate, improved the blood test, and improved the rickets in these patients. And so I was unaware of this till I was told about it by Dr. Hohenfellner, she runs this huge cystinosis clinic in Germany where pretty much everybody in Germany who has cystinosis goes to her. And she uses a little bit of hydrochlorothiazide, and she feels that it really reduces the requirement for electrolytes. So that's interesting. I haven't started that with any of my patients, but I'm thinking about doing that. Potassium is also something which, I got 2 more minutes? 1 minute? No minutes, okay. So I think I'll stop here because I was just gonna say that what we're learning is using some diuretics may actually reduce urine output, might improve the quality of life, and might actually help the patients. And so this is something which we're working on to keep them as healthy and as having as normal growth and nutrition as possible. And I think what's important is, as we talk about this amongst cystinosis community and clinicians, we continue to improve people's care. Anyway, thank you very much. All right.
Thank you, Dr. Grimm.
Okay, I'll just give it back to you.
Do we have any, just burning questions? We don't have a lot of time, and I want to remind you that we have these cards here and that Dr. Grimm will be speaking first thing tomorrow morning. So you could always save your questions till then, but we have time for 1 or 2 questions, if anybody has any.
Oh, hi. My daughter's 2 years old, and one thing we often discuss with her nephrologist is whether the body's different at nighttime and if you need maybe less of these electrolytes. For sure, we give her bicarb and she gets a lot of gastrolyte, but just because of her tolerance ability, I wonder if you had a thought about that, about your body at nighttime versus daytime.
So if your kidneys work normally, the brain sends a signal called antidiuretic hormone at bedtime to make your urine flow really go down so that you can sleep through the night and not wake up to pee. In patients with significant cystinosis, the brain can't send enough of that signal to the kidneys for the kidneys to listen. So most of these children do pee a lot at night, and that doesn't go down. But for giving electrolytes at different times, I'm not aware of any data on whether that needs to be different if they're, say, walking around or if they're sleeping. All I know is that the more electrolytes you give whenever you're giving, the more they pee. So sometimes parents will prefer to give their electrolytes during the day, so they might not pee so much at night and sleep a bit better, just for the sleep. And others, they just want to get it in, and it doesn't really matter because the kids just pee in pull-ups and it doesn't make a difference. So I think that sort of depends on what you're valuing from a quality of life perspective. Okay. Is it good?
Any other, one more question? No? Great. Oh,
So how long should you said you keep calcium away from potassium, right? How long?
Oh, calcium away from Procysbi. So,
Yes.
right. So with Procysbi, see, all the calcium preparations are antacids, and so they're sold like Tums for the tummy to reduce stomach acid. So if you give calcium or bicarbonate too close to the Procysbi, it just neutralizes it. So in little kids, probably an hour is good enough, like little babies where everything moves quickly. But in older kids or people who are on dialysis or people who have delayed gastric emptying, where you know your child, if they vomit, you're going to see the color of their meds from 3 hours ago or 4 hours ago. It should be a couple of hours, maybe even 3 or 4, just because if it sits in the stomach together and all mixes together, then it's going to neutralize the effect of the Procysbi and it's going to release those granules. So it depends on how well the kid's stomach functions. Okay. Does that help? Yeah. Okay.
okay. Thank you, Dr. Grimm. She says she'll wait. So make sure you use your cards and we'll get to all the questions. So next we have Dr. Julian Midgley. He comes to us from Canada. He is at Alberta Children's Hospital. He's a pediatric nephrologist, and he's speaking about the very challenges of cystinosis for young adults and adults.
Hello, everybody. So I'm going to talk a little bit about adults and cystinosis, and looking forward to hearing more. And I'm very pleased that Stephen and Paul have talked a little bit beforehand, because that means that I can move over a couple of things. So I'm from the Alberta Children's Hospital. This is a picture of it. It looks kind of like Lego, but nothing to do with cystinosis, I guess. It doesn't quite look